Risk adjustment, clinical documentation specificity. Today we're going to talk about dementia, the diagnosis specificity needed to assign the appropriate diagnosis code, and the clinical documentation requirement to support the ICD-10 submitted on your claim. The goal for today's content is to obtain a high-level understanding of risk adjustment specific to dementia. We'll be utilizing the CMS HCC Medicare risk adjustment model. The information shared today is in accordance with the CMS Risk Adjustment Data Validation Guidelines, the ICD-10 Coding Guidelines, the American Hospital Association Coding Clinics, and industry best practice suggestions for risk adjustment success. We hope that you learned one thing today that you didn't know or that wasn't clear about risk adjustment, clinical documentation, and/or ICD-10 coding specific to dementia. And we also hope that you take away a tip to ease the burden of the day-to-day documentation requirements by implementing small changes to get credit for the work you're already doing. Please recall the clinical documentation specificity best practice specific to risk adjustment data validation audits. It's the one standalone progress note. It's not the medical record in its entirety that's used in an audit. It's one data service and a single progress note that must validate the ICD-10 HCC diagnosis code submitted on your claim in risk adjustment data validation. Does the clinical documentation in your progress note meet the CMS MEET criteria to support the diagnosis codes in your assessment and submitted on your claim? Remember, MEET, M-E-A-T, monitor, evaluate, address, treat, the CMS acronym that you should include with all chronic diagnoses in your progress note documentation. Here we're going to talk about some specific documentation tips for dementia. Dementia is a chronic or persistent disorder of the mental processes caused by brain disease or injury and marked by memory disorders, personality changes, and impaired reasoning. The number of people living with dementia worldwide is currently estimated to be 50 million and projected to increase to 82+ million by the year 2030, with the number of cases expected to triple beyond that. There is a lack of awareness and understanding of dementia, resulting in a stigmatization of barriers to diagnosing and care for patients. Dementia has a physical, psychological, social, and economic impact not only on the patient, but also on their families, caregivers, and society at large. Alzheimer's dementia is the 6th leading cause of death in the United States. Dementia is a group of thinking and social skills that interferes with daily functioning and difficulties with specific aspects of memory, which are suggested by certain problems in day-to-day activities. For dementia, age 65 and older is the age range of the greatest risk for these conditions. The percentage of people who have these conditions increases with age. A 12% increase in the prevalence of this disease is expected by 2025. An estimated 5.8 million Americans of all ages are currently living with Alzheimer's dementia. From the year of 2000 to 2019, the number of deaths attributed to Alzheimer's dementia has increased by 145%. There are different types of dementia, different causes of dementia, specific cognitive changes, and psychological changes. The types of dementia are Alzheimer's, vascular, Lewy body, front temporal, and unspecified. The specific cognitive changes to be aware of are memory loss, difficulty communicating or finding words, difficulty with visual abilities, difficulty with reasoning or problem solving and handling complex tasks, difficulty with planning and/or organizing, difficulty with coordination and motor functions, confusion and disorientation. How to further specify diagnoses specific for dementia. Consider screening any patients that have been diagnosed with age-related cognitive decline, memory impairment, and/or memory loss, which are all non-risk adjustable, non-definitive diagnoses. You'll want to screen them for a more definitive / specified diagnoses, such as dementia when appropriate. Currently, there are no official screening requirements for dementia. Best practice suggests including a mini mental status exam during your standard annual Medicare wellness visit. Conversation with the patient may be as important as any formal cognitive assessment. The presence of word-finding difficulties, inappropriate behavior, and/or paraphasia are clinical indicators worth further assessing and looking into. Risk factors for dementia include advanced age, a lower socioeconomic status, a female gender, a family history of first-degree relatives with dementia, a history of mild cognitive impairment. Cardiovascular risk factors for dementia are modifiable such as hypertension, hypercholesterolemia, type 2 diabetes, obesity, tobacco use, and physical inactivity. Regarding behavioral disorders or disturbances, according to the NIH, up to 80 to 90% of dementia patients suffer from some type of behavioral disorder. Here's a list below that's not all-inclusive, but things such as agitation, aggression, wandering, purposeless activity, binge eating, urinary incontinence, sleep disorders, and so on. Some common presentations of dementia include any detection of cognitive impairment. So for most annual wellness visits, there's a requirement for reimbursement of the 6-item cognitive impairment test. If you detect any cognitive impairment, it may be a presentation of dementia. If there's a decline or problem with memory, forgetfulness, orientation, awareness of time, place, and/or person, any mood or behavioral problems such as apathy, being uninterested or irritable, loss of emotional control, easily upset, irritable, and tearful, and difficult in carrying out usual work, domestic and/or social activities. Regarding the fact that dementia is very underdiagnosed, we've taken a look at mild cognitive impairment. G31.84 exists on a large number of our Medicare patients across the nation. G31.84 is a code for mild cognitive impairment, which is not included in the CMS HCC model. In order to have a diagnosis of mild cognitive impairment, there is a requirement for evidence of a decline in memory and at least one of the following. Does your patient have the ability to generate coherent speech or understand spoken or written language? Does your patient have the ability to recognize or identify objects, assuming intact sensory function? Does your patient have the ability to execute motor activities, assuming intact motor abilities, sensory function, and comprehension of required tasks? And does your patient have the ability to think abstractly, make sound judgment, and plan to carry out complex tasks? If your patient lacks in any of those following and has a diagnosis of mild cognitive impairment, consider further specificity of a more definitive diagnosis, specifically when you have an altered mental state, mild cognitive impairment, memory loss, age-related cognitive decline, etc. It may be wise to pull a report of patients that have mild cognitive impairment or any of the others that are listed here on their problems list to further evaluate and specify a more definitive diagnosis if appropriate. For dementia to be diagnosed, in addition to meeting the criteria for mild cognitive impairment, the cognitive deficits must be severe enough to interfere with daily life. The primary care physician must screen the patient for abilities to perform activities of daily living. Interviewing the family members and/or caregivers is important, specifically documenting these findings in the progress note for a more definitive diagnosis. When documenting dementia, include the following. Best practice for documenting dementia would be to include some or all of the following. Specifically the type of dementia. Is it senile, pre-senile, vascular, etc.? Is there an underlying neurological condition? Any information regarding presence of delirium, delusions, or depression? And are there any behavioral disturbances present? Any aggression, violence, or combative behavior? A couple of examples of some great documentation regarding dementia. Example 1, 88-year-old male here with Alzheimer's disease in the office from the nursing home for a checkup. In the assessment, patient with late onset Alzheimer's dementia, Caregivers reported recent increase in agitation and wandering. The physician's going to increase the patient's medication and start a new medication. Those ICD codes that are covered in this particular example are Alzheimer's disease with late onset, G30.1, dementia and other disease classified elsewhere with that behavioral disturbance, F02.81, and then wandering and disease classified elsewhere, Z91.83. Specifically calling out that this particular paragraph definitely supports the appropriate diagnosis code for Alzheimer's or dementia. Example 2. In the HPI, 76-year-old female with vascular dementia being seen today because of worsening depression. She's here with her husband. In the assessment, patient with vascular dementia due to a history of stroke and mild recurrent major depression. She's experiencing increased fatigue and a depressed mood. They're going to increase her medication and specify that the patient see a neurologist tomorrow. The codes that would be appropriate to assign in this particular example are Z86.73, personal history of TIA and or cerebral infraction without residual deficit, F01.50, vascular dementia without a behavioral disturbance, and F33.0, major depressive disorder, recurrent mild. Let's not forget the principal goals of dementia care, which are early diagnosis in order to promote early and optimal management, optimizing physical health, cognition, activity, and well-being, identifying and treating accompanying physical illness, detecting and treating challenging behavioral and psychological symptoms, and providing information and long-term support to caregivers. Thank you for your attention today. We really do appreciate all you do. And remember, it's the small changes made today in your clinical documentation that will make a huge impact in the future. Thank you.